In our interactions with, your large payer side, they have a membership, they have a fiduciary responsibility, and they understand that. The quality control measures they put in place are just to make sure that there's an overly expensive healthcare delivery. And when they implement those, it's not meant to be malicious. It's meant to provide equitable care. And we have to have some cost containment. And so in our discussions with the payer side is we help them support and validate why they administer the dollars they do. And then they're able to track that in their claims data and develop strategies internally to cost contain a little bit more, but maybe fine tune with their relationships with the payer side, the dialogue that goes on in terms of how are we managing these patients. It's more cost effective to us both if we approach it from this direction, and usually it's based on a tool, a decision tool, and data that they've accumulated, and the tool being MCG. Sometimes there are claims that go through the process, through the contractual agreement, 1, 2, 3 appeals. If we're in a position and we feel strong enough based on MCG and MCG claims, base claims, that we feel that the evidence there supports that patient, let's say, needed to be in an inpatient environment versus OBS, we'll ask for a meeting, and we may pull 15 different claims that may be kind of hot at that point, elements of contention. We feel that they've been administered incorrectly or the wrong decision. We've exhausted everything, and we set up almost a pseudo peer-to-peer at that point. Peer-to-peer may have been forward in the stream of things. That opportunity didn't present itself. But we do have what we call representatives within the provider side as well as the payer side that we go to, and then they make arrangements for those meetings. We set up a conference call, and we'll review those claims in detail jointly. We develop a better understanding of how each of us think, and sometimes those social discriminants weren't identified initially in the review. And it allows us to say, do you think that might have impacted the readmission on this patient? Or you denied this claim up front as a DRG readmit. I know you triggered COPD on both of those, but the first submission was for this, the second mission was for this, and using MCG guidelines, both were legitimate inpatient visits. And by the way, the patient was non-compliant. You provided a medication, they stated in the record they didn't use it. So it changes the whole scenario in how the payment is administered to the provider and how the member is recognized as a compliant patient on the payer side.